Welcome to Oral Systemic Connections, the people and technologies leading the medical dental integration. This is an international webinar. It is absolutely my pleasure. My partner, Sue Ruslan in Australia, and her counterpart, Nicole, are hosting this for Dr. Bax and myself, and I am massively appreciative of the lengths that they've gone through to make this happen on very short notice. And our vision is to really spread this message worldwide, and Sue's making that happen. So I've been at this for a little bit over a decade, and one of the things that I've done is compile a lot of research on my website. I think I had 100 research articles about various kinds of oral systemic stuff, and people said, "Hey, can you send me an article?" And then Dr. Daniel Amen comes along, and he's a brain specialist, and his claim to fame is that he's looked at over 250,000 brain scans. That's 250,000 brain scans, and this is a very compelling minute.
You want to increase inflammation, which is a root cause of so many medical and mental health issues. Never floss. Don't really care about your teeth. So if you want to love your brain, you have to love your mouth. It's absolutely critical for you not to have gum disease, because if you have gingivitis, odds are you're at increased risk for heart disease and depression and dementia. It's fascinating. Like, I didn't learn about this, and I didn't really care about my teeth until I started seeing the links between gum disease and heart disease, gum disease and brain disease, and now I'm a flossing fool. But if you want to damage your brain, don't care about your mouth, about your teeth. Don't ever eat fish. People who have grilled or baked fish once a week have more gray matter in their brain. People have low levels of omega-3 fatty acids, have smaller brains.
Okay, so if anybody asks me any oral systemic questions, I send them a TikTok now. How about that? I want to make a comment about self-empowered healthcare. I think everybody that's here today is here for a specific reason. We all know our healthcare system is broken. It's almost irretrievable. It's so badly damaged. And there's a trend taking place, which I call self-empowered healthcare. So I'm going to show you some of the cast of characters. Mark Hyman from Cleveland Clinic, Peter Attia, Dave Asprey. These are all, I guess, what you would call influencers. Gary Brecka is kind of new on the scene. I'm kind of fascinated with Gary Brecka. Gary's past history, he was an actuary for a life insurance company, and his claim to fame is that he can tell you exactly when you're going to die. And he got very disillusioned with that profession and jumped into functional medicine, and he's created this whole program called 10X. The reason that I mention him and give him any attention is because of who he's running with. We need to understand this concept of influence, okay? So his world includes Joe Rogan, Dana White, and who am I forgetting? There's somebody, I wrote it down. I'll think about it in a second. Grant Cardone is the other person. These people have massive, massive influence. So I'm not going to play his video, but in this video, he talks about going to the dentist, looking at bacteria under a microscope, and you need to go to a biological dentist. Now, let's say he has 500,000 viewers on this podcast. At any point in time, in any community, if someone was to go and look for a biological dentist, I would say their chances would be less than 10% in finding one, probably less than 5%, okay? Dentistry is massively underrepresented in this whole concept of self-empowered health. This is Tony Robbins, Fountain Life, okay? I don't know how many of you know about this, okay? So Tony's last project was finances. He wrote a book about 401ks and your money. He has shifted to preventive healthcare in a massive, massive way. So Peter Diamandis, MD, is the head of Fountain Life. There's a press release right here from last week. Fountain Life acquires Precision Health Technology Company. Okay. You want to talk about horsepower. I mean, I'm on their mailing list, and you ought to see the clinics that they're opening. And it's all preventive based things. This is in response to our broken healthcare system. So here's my question. In the race for technology-based preventive screenings and services, dentistry is for some reason mysteriously absent. So if Brad Bale is saying that the mouth has a 50% contributory factor to inflammation, if Daniel Amen says your brain health is absolutely critical, that your mouth is healthy, why are we not anywhere to be found in this conversation? So this little portion that I'm going to do right now was Craig and I did this about a year ago. This was a very, very popular webinar. So instead of my 10-year perspective, this is my 11-year perspective. So a little bit about Dr. Bax. He's the CEO of Cure Coach, software and hardware to empower cure for chronic disease. Craig is a tireless worker. He's been at this. He's very dedicated and very committed. Chief Medical Executive for the Cure Center for Chronic Disease. So what we're talking about is root cause analysis. This is not Western medicine that is based in reactive care. Reactive care is you go in with a problem and they give you a prescription, okay? In functional medicine, it is what is the root cause? Extinguishing root causes yield much better results. So here's the problem. The problem is heart attack, stroke, dementia, diabetes, insulin resistance, metabolic syndrome. I think Craig uses the word diabesity. This is the main area of focus. This particular slide right here, the reason why this came up, if any of you are college football fans, there's a big controversy right now about the college playoff system. And there's a YouTube video that's been in circulation all the past week about Coach Mike Leach, who passed away last year suddenly of a heart attack. And Coach Leach was talking about the playoff system, and he predicted that what happened last week was going to happen. He was a brilliant coach, really funny, clever guy. Probably the only mistake he ever made in his life is he didn't have Dr. Bax as a physician. So this is the BaleDoneen method, which we're going to talk about. If you've never read The Heart Attack, Beat the Heart Attack Gene, you know, that's got to be on your book list. Dr. Bax and I actually went through the preceptorship at the same time. We did not meet. We subsequently met, but we did not meet at this preceptorship, even though we were trained at the same time. This is 2013. It created a pivot in his medical life. It created a pivot in my dental life. So this is the BaleDoneen method, root cause. And so on the bottom of the slide here are the root causes of inflammation. Inflammation is the target, extinguishing inflammation. So in theory, if you can extinguish all of these contributing factors, you have put yourself in a position of being, you know, safe from the standpoint of heart attack and stroke. So this is Dr. Bale and Dr. Doneen, 2016. They came to Lexington, and I got them an adjunct professorship at the University of Kentucky College of Dentistry. Dr. Bale is a graduate of the University of Kentucky. So here's what I learned in 2013. The new focus on inflammatory supportive diagnostics from the dentist. The dentist now has a seat at the table. And I keep talking about the dentist being absent in this whole functional medicine conversation. Well, they're not in the BaleDoneen method. You have periodontal risk assessment, sleep apnea screening, endodontic risk assessment. So let's look at periodontal disease. We are not talking about the conventional exam. We're talking about the microbiological, the bacterial assessment. That's where the risk lies. So on the left here is a Leica microscope. That's my wheelhouse. I've been training individuals. I created the first virtual platform to train chairside hygienists or doctors how to use the microscope chairside. That's the program that Sue is doing in Australia, and she's now doing it in Asia. Now, on the right is the HR5. That's probably one of the most advanced salivary tests right now. And if you look down here, this is the deeper dive that the functional medicine doc needs to know which one of these pathogens, and then here are the disease risk factors, the different things that can happen, right? So that is what is required from the dentist. Now let's look at obstructive sleep apnea, which has long been a risk factor. So as far as a screening capability, when a dentist has a new patient intake, some of the new CT scans are pretty cool. We can look at airway or do a very, very preliminary screening with a Mallampati score, Epworth sleepiness scale, stop bang. Those are some of the few things. And what that does is it tells you whether or not you need to go to the next step, which is a sleep study. Endodontic disease. This is probably the most interesting, and I've had a lot of conversations with Dr. Bale about this. Probably every dentist on this webinar has this tooth in their practice. This tooth is asymptomatic. There's no swelling. There's no tenderness to percussion. It just has a nasty lesion on the end of the root. I don't know exactly how Dr. Bale backed into this, but he basically, one of the things that he requires is a CT scan. And what he found was if a person has an elevated inflammatory markers and that tooth is taken out, that those markers fell. And it kind of became a part of the BaleDoneen protocol. So I saw this from Dave Asprey. He's one of the people that I showed you a little bit earlier. And I'm comfortable with this. I know Dr. Bax is comfortable with this, but it's a little bit different perspective. Okay, so in traditional Western medicine, if we do not know the correlation, then it's no good. We throw it out. But if I do A instead of B and it makes me better and I can measurably prove my markers of inflammation and markers of aging, we can figure out why it works later. Here's why that statement is important. If Dr. Bale had this theory about endodontic lesions and he went to the American Academy of Endodontics and he goes to some university and they're going to do a study and it's going to be 10 or 20 years, okay? But basically, anecdotally, he takes a tooth out and a person has a myeloperoxidase of like 1300. That's one of the inflammatory markers. The tooth comes out. 4 weeks later, the myeloperoxidase is 300. Hey, that's interesting. Maybe that tooth contributed. Then he did it again, same result. Then he did it again, same result. So what I'm saying is, if he does A instead of B and the markers, we can figure out why it works later. But the reason why the endodontics it's very controversial. And this goes back to Weston Price in the 1930s, who talked about the dangers of leaving residual tissue in a root canal. Okay, and I'll let you do your own research on that. That's the root of that whole controversy. But so that's why the endodontic things. So here's a proof in the pudding. This is me. This is my most recent labs. This is the first time, I think, in a decade that I ran the table, everything in the green range. The BaleDoneen method, when you get your first labs, it can get your attention, okay? There's a lot of stuff to get in line. The HR5, no AA, no PG, which are the things that I'm probably the most concerned about. And then we're going to talk a lot about ultrasound. That's actually the subject of our webinar tonight is the carotid ultrasound. So the CIMT, and I'm gonna ask Craig a couple of questions here in a minute. So the carotid intima media thickness examination, the benefits, it's non-invasive. It gets you a baseline. So that's what's critical in the BaleDoneen method is you need some sort of a baseline. I'll ask Craig, but I think probably 40 years old, you should have a baseline. I don't know, maybe he might say younger. The challenges are expertise and equipment. And this is something he's been working on, and this is something that he has overcome. So I'm going to ask him, I'm going to ask Dr. Bax to kind of jump in here because this is one of his slides. This is a really, really nice illustration of that intima layer in the artery. Craig, can you kind of describe this process from left to right that we see on the screen?
Certainly, thank you. And this is my opportunity to thank Sue for putting this together at such short notice and the time of year where it's hard to get anybody's attention. But I'm really happy for the opportunity to share this information and other opportunities. So when I sit down with a patient, this is the image that I spend the most time with. And the idea is, and I use analogies, metaphors. I'm not a real geek about studies and quoting literature and statistics. And I think that proves how much we know. But I think for the average patient, even those that are fairly sophisticated, often they know things that just aren't so. But the point is that keeping it relatively simple. So I use the analogy of acne. To me, an atherosclerotic plaque is like an acne pimple. Now, that may not sound so attractive, but I think it gets the point across. And pimples rupture and they lead to blood clots, or they can go on to heal and become scars, which is more of a problem. It's the active inflammatory lesion called plaque that develops as a result of inflammation in this intermediate layer, which is way too much to go into the detail, but ultimately oxidized LDL and other materials are the fuel, and inflammation driven by a variety of sources, insulin resistance, periodontal disease, endodontal disease, chronic oxidative stress, pollution, etc., all contribute to this. And to get it to quiet down and to settle down and to reverse, you have to address those underlying inflammatory drivers. Not so much the fuel, the cholesterol, sort of important, but maybe not as important as we thought, but the inflammation is really the key. So anytime I'm talking with a patient, I would say, would you rather be here, where we're calling the ambulance or the cath lab or the coroner, or would you rather hear it from me that you have a little bit of arterial disease, which is like having a little bit of cancer or a little bit of an infection? You wouldn't want to wait till there's more to deal with it. Deal with it now. And here's the kicker. It's reversible. The BaleDoneen method has taught us that this disease process is not only can we stop the progression, it is absolutely reversible, but not by the standard means, not by the usual standard of care, medical care that people are accustomed to. If you ask ChatGPT how to reverse arterial disease, it has no idea because the information going into the artificial intelligence is so uninformed, so disinformed, if you will, so misinformed that it can't get the job done. So that's what we're all about here. Is one of my favorite quotes is from Buckminster Fuller: you don't change things by changing the existing paradigm. You create the new paradigm that makes the old paradigm obsolete. And that's what we're all about.
Nice. Oh, I love that. Okay, so Craig, I want you to just spend a second and define these terms, okay? Because this is going to come up over and over again. And what we're talking about the plaque in the arteries,
right.
Homogeneous, heterogeneous, and echogenic. So explain those terms to our audience.
So echogenic just simply means that it creates a white spot on an ultrasound pixel. Non-echogenic, that's this area here. So the lumina of the artery, this is the artery in longitudinal view, is non-echogenic. The surrounding soft tissues have a variety of echogenic materials. One of the most echogenic or white bright spots is calcium. So a plaque, again, going back, can we go back to that previous slide? A new plaque is like a fresh inflammatory lesion, a pustule or a pimple. That's otherwise known as soft plaque or homogeneous plaque, because and it's very tricky to find because it's not very white, it's black. It's a lot like the surrounding tissues because it's like a fresh, non-organized inflammatory lesion. So that's about, that's how it all starts out. And guess what? That's when it's most likely to rupture. That's when plaque is most likely to rupture, when it first forms. Then it goes through the process, just like with any inflammatory lesion. It goes through a healing process. That's heterogeneous, echogenic plaque. It's getting fibrous material, some calcium material. It starts to look like this material here. You can see it's gray to white. But this is non-echogenic or soft plaque. And then the ultimate process is for this to stabilize and to heal and to become calcified. So one of the key things is to understand that calcium does not cause arterial disease. Calcium is a consequence of a chronic inflammatory process and is actually a good sign. A higher calcium score with any given plaque can mean new plaque forming, but if the patient's under active treatment and they see their coronary calcium score go up, guess what? They're doing well. But a lot of people misinterpret these studies, use them in the wrong way, and send patients right down the pathway to the slippery slope to a stent or surgery.
Yeah. So you got ahead of me here, because that was my next slide and my next question. I personally got massively confused on this, and I think there's more confusion around this than anything else. And so what you just described is this transformation of soft plaque to the intermediate to the calcified is going to have you have an increased calcium score. And that's what happened to me. And I was like, well, hell, my calcium score is going up a lot. What's going on? Okay, and then that was just me being ignorant, right? Not understanding. But actually, that's taking soft plaque and stabilizing it. And I think there's probably more confusion around this. And especially like, let's just say a physician said, a physician that's not really clued in on this might say, well, go get a coronary calcium score, right? And then the patient goes and gets that, and whatever. You're definitely, if you have a low score, you're not home free. That's for damn sure, right? And then if you have a high score, it could be stable. So this is an area that I think really needs some explanation. And thank you for that was my next slide, and you led me right into it. Okay, statins. So let's talk about that, because once again, I do follow there's a certain number of people I follow on social medias, and statins still seem to be a part of the I don't know, I don't want to say controversy, but there are people that are anti-statins. So here's my understanding. And once again, I'm just going to tell you, I consider myself as a lay person, as a patient, saying my understanding of the statins are, it's not so much about lowering the cholesterol, it's the added anti-inflammatory effect, and that the statin aids in this process that we're talking about, right? And I don't think that story is told properly enough. So I'm going to give you a chance here, Craig, to straighten this out.
Oh, just years and years of controversy in about 2 minutes or less. No, it actually is pretty straightforward. The LDL cholesterol lowering effect of statins is actually a side effect. And we use that side effect to monitor whether patients are actually taking their medications. I run into all kinds of statin attitudes, but for the most part, there's at least statin skepticism, if not statin phobia, and statin fear and avoidance. For the most part, though, I need after I explain to patients what the real purpose of statins and their real mechanism of action, we may not get buy-in right away, but when we see that the results aren't what we want, we often end up going there anyway. So it's a whole negotiation. But here's the key thing about the statins get a bad rap. I was going to say for 3 reasons, but I think there's actually 4 reasons. One, they're prescribed at too high a dose, so you have a lot of side effects.
Right.
The wrong statin, they're either not, there's a genetic component. Atorvastatin is ineffective for a significant segment of the population because of a genetic variation called KIF6 genotype. And guess what? It's the most widely prescribed statin. Lipitor had the best marketing campaign. It was the darling of the pharmaceutical industry until it went off patent. So they're prescribed at too high a dose for the wrong reason. And then the wrong statin. So the wrong reason is they should be prescribed for anti-inflammatory effect to reduce intimate media thickness and inflammation markers. And you use the cholesterol numbers not to drive down to a specific number like the cardiologist tool do. I constantly, I don't mean to be, I don't know how exactly to deal with my colleagues. I'm just going to say I'm very disappointed, but I'm also very understanding that to a large extent, a curious medical doctor will not be happy in the current healthcare system because they're like soldiers. They're told, don't be curious, follow orders. And that's really the fundamental problem with our healthcare system. It's become a top-down, authoritarian, captured system, with the exception of independent practitioners and other, but that's a whole other side. So I generally prescribe low-dose rosuvastatin, 5 milligrams 3 times a week, often 2 times a week, maybe even half that. And we see a reduction in the inflammatory markers and the lipids. And for patients who are not comfortable with that, there are supplemental alternatives that work nearly as well. I'll add a 4th reason why the statins are getting a bad rap right now. They don't make any money for pharmaceutical companies anymore. So if you can convince a patient they're statin intolerant, then you can get them on these $6 to $1,000 monthly injections, these PCSK9 inhibitors, as an alternative, which are as far as I know, are no more proven to reduce heart attack or stroke risk than statins or lifestyle changes. Sorry, that was more than 2 minutes, but it's a complex topic.
Okay. So once again, lipids, that was a couple of tests ago. So I've never had issues with lipids, so to speak. Can you just kind of touch on the topic of fractionation? Okay, I
Sure.
barely say that word. Yeah.
So this is part of the advanced lipid testing. It used to be the Berkeley Heart Lab. It's been bought up by Quest, and the Cleveland Heart Lab does this. There's several methodologies for doing this. Cleveland Heart Lab does ion mobility. There's also NMR is another option. I happen to do all my stuff through Quest and Cleveland Heart Lab. So you have your HDL, your so-called good cholesterol, your LDL, your bad cholesterol. And there's this guy over here called lipoprotein A, which is getting a lot of notoriety right now. Why is that? There's some new drugs coming down the pipeline to treat lipoprotein A, and they're going to make a lot of money because now it's been ignored until now in the United States, although pay attention to in Europe. And then LDL is not just one particle, but there's a low risk, large, buoyant LDL. And there's higher risk, small, penetrating, small high density LDL. If you have more of these small dense LDL, that's higher risk for any given level of LDL cholesterol. And guess what? It also predicts the most common driver of inflammation, that is insulin resistance, the pre-diabetes. So 15 years ago, we started patting ourselves in the back. Now we're not just waiting until people get diabetes, we're paying attention to pre-diabetes. Now, but the real opportunity lies, that's just the tip of the iceberg. The real burden of chronic disease is in the insulin resistant pre-diabetics, so people walking around with normal blood glucose, but very high insulin levels and chronic inflammation. So this small dense LDL is a very reliable indicator of that metabolic disorder. You've heard of metabolic syndrome, high waist size, high blood pressure, high triglycerides, low HDL, and glucose over 100. So these are all. This is a fairly reliable indicator that I usually get at one time, just to kind of screen for patients. A lot is made about trying to change this with certain medications, but I think that's more of an academic discussion than it is a pragmatic discussion.
Very good. Speaking of insulin resistant, this is the part that always, me personally, I'm amazed at. So my last A1C was 4.7. I've just got diabetes rampant in my family. I do not understand exactly how I've dodged this bullet, but I'm just going to continue to be amazed by it because I just know it's important. So that's another area of success. Inflammation.
Stay lean, my friend.
Well, yeah, that's my daily struggle. Talk to my wife about staying lean. So advanced inflammatory markers. Okay, I think everybody is, most people are familiar with CRP, but actually kind of take this a little bit further. I talked about myeloperoxidase earlier because one of the things that you've taught me is the relationship between myeloperoxidase and oral issues. Mine has always kind of bounced around, but it's kind of gotten back down to a normal situation. So that whole concept of when you see that elevation, you need a dentist. You have to have a dentist involved in that to say, root cause. I need to know: is there a root canal? Is there an abscess tooth? Is there an infected whatever? Right. So that's an important part of the equation. So this is the wellness center model. I show this slide all the time. It's 2009 when I was my first couple of months at the University of Kentucky. I said that the biological health oriented practice is the largest emerging market opportunity in history. And then in 2023, my friend Chris Phelps says that holistic dentistry is the fastest growing niche in dentistry. And this is a phrase that you use in relationship to the carotid ultrasound, but I use in relationship to the microscope. This is us showing the biofilm, the live biofilm to a patient, and your quotation is, "And now that I have your attention," right? When you do that carotid ultrasound and you show them plaque, now you have their attention. Well, there is nothing equivalent to video microscopy in grabbing a patient's attention. It's immediate. Sue has seen it in all the practices that that she's deployed this in across Australia. It's very, very compelling. Okay, so we're here to talk a little bit about the butterfly ultrasound, and I've got a backstory here. So it was either 5 or 6 years ago when I was, I've been constantly trying to work. I've been working on this integration, and my wife works as a medical interpreter, and I saw that Cleveland Clinic had a functional medicine coaching program, and I think it was a 1-year program. I said, this would be kind of cool to take this course and then also to be trained in doing a CIMT, to be able to do those. And then I have this relationship with these dentists here locally, and I have a physician that I sent to BaleDoneen. He was kind of a moving target. I couldn't quite get my arms around him. Well, here's what we found out. So she went and, we bought the equipment and did the training. And it was just a little bit more complex at the time than I couldn't piece it together, right? So 2 or 3 years ago, Craig was starting to tell me about the butterfly and how he was, and I've watched it progress because he's been a presenter at my meetings on the hands-on part. And I was like, wow, now we're getting somewhere, right? Because the whole issue with this is accessibility to this exam, okay? And most communities don't. If I go to a BaleDoneen physician and I need a CIMT, I might have to travel somewhere to get this done, right? So this is something that Dr. Bax has been working on tirelessly. So I think this is 2 years ago. This was the first time he presented at my my annual event. And I saw this and I was like, this is so cool. I can see right there. I can see on his phone. You can see right there that plaque and that, and this is a young person, right? And so he demonstrated how he has definitely simplified this approach. Now, one of the things that he has done since then, which is going to be kind of the second segment of this webinar tonight, is he can now do a CIMT level report from this. Okay, so 2 years ago, he was just doing the screening. Do you have some soft plaque or not? Okay, it was kind of a preliminary screening, and there really wasn't a call to action at the end of it. So on this lower image right here, it is that's an amazing image. So 5 years ago, like I said, my wife was formally trained, and we just couldn't put it together at that time. So here's our problem. Western medicine's stuck in the reactive model. And what Craig and I both know and we're both dedicated to is some sort of an integrated model. It's a work in motion. Craig works on it every day. I work on it every day. And so I put this back up here and I say, why is dentistry absent? So here's my pitch. This is my annual meeting. And basically the concept behind my meeting was I wanted to put these instruments of advanced prevention in people's hands. So the second day of my meeting is hands-on. It's in a clinic, and we do clinical rotations. So you're going to have an ultrasound probe in your hand to see how it works. You're going to have a laser in your hand, air polishing in your hand, sleep screening, how to do it, salivary diagnostics, how to do a salivary exam. So I've been kind of in my own way trying to be that person, as small as I am, trying to move that needle to the things that we need to do, because as I showed you earlier with all these influencers on the medical side, they're way ahead in convincing people that they need these services. So we need to get on board so that we can work with them. They're gonna set the path for us. So there is the contacts for Dr. Bax and for myself, and I am going to turn it over to Dr. Bax.
Okay. Well, thank you, Tom. Share my screen here. Everybody can see this. So this is from my website, and Tom stole most of my thunder, so I don't really have a whole lot more to say. Um, so, what he said is true that about up until about 6 months ago, this is a relatively recent development. What I could show a patient is whether their artery was healthy, viewed in cross section, or whether they're starting to see some inflammation in the intima media layer or frank plaque formation. And I just want to maybe clarify a bit. About 4 years ago, maybe five, I called my practice the Center for Prevention, Heart Attack and Stroke. But what I was finding is that human beings were weird. We like to think we're rational and think in terms of statistics, and everybody knows an ounce of prevention is worth a pound of cure. But when do people act? Not so much in the way of prevention. They're not driven by data, they're driven by emotion. And really, we're much more reactive. And so that's why I changed from the cure center, because we aren't really preventing arterial disease in our practice. We are finding it at an earlier stage and doing a medical and lifestyle and supplement intervention, not a procedural intervention, but an intervention nonetheless, and reversing the condition, because most people won't act until they feel the pain in some sort. And that's what we meant by getting your attention. And there's a whole joke about a farmer and a mule that goes with that, but I don't have time to tell it tonight. The point, though, being is once we can show somebody that there is as I mentioned, a little bit of disease or a little bit of cancer, a ticking time bomb, a threat to their life and their life as they know it, then we can get them to act. So I've had 3 point-of-care ultrasound devices in the last 5 years, and they've come a long way. The first one I had was a GE device. It cost me about $12,000. It's now a very expensive paperweight, and my practice is paperless. So what's the use of that? Because it allowed you to do two areas of imaging. The images weren't very good. Next came along one called a Sonon, $6,000. And the images were better. It had more bandwidth, but it was still kind of disconnected all by itself. You could store the images on an iPad or on your phone wirelessly, but it still didn't quite catch it. Then I discovered this device, and I get no commission from Butterfly, but I did invite the people that I know from there. I know Pam Kelly, who's a sales rep who works with us most, is also on the meeting. And part of I'll be perfectly transparent. Part of what caused me to contact Tom to hopefully try to arrange something now is that there is an opportunity to get these probes at a lower cost now until Christmas than in the past. And so I know this isn't a commercial presentation, but the timing of this is such for anybody that might have been their interest raised by a previous webinar or previous contact with Tom or myself, now might be a good time to consider this. But the quality of the images, I'll just show you. If you can take so the next thing is, okay, why in the dentist's office? Well, you guys see patients twice a year, sometimes 3, sometimes 4 times a year. A patient might not see their medical doctor for several years. So, and then the other issue is if you want to get a basal, let's say a lifeline screening, well, they'll be in your community maybe 6 weeks from now, 6 months from now. The typical providers of the CIMT studies. There's basically 2 that I would trust nationwide to provide consistent studies. And, I send people all the time, oh, we'll be here. We don't have anybody in that community. In fact, I'm going to talk to you about an example here in a bit. The closest, a gentleman who's a healthcare worker in I believe the San Francisco area, not the middle of nowhere. We would have to drive 3 hours to get a CIMT. He had a duplex ultrasound, probably 5 or 6 different locations within a mile in San Francisco, but that's not what we're looking for. So, there's a need for access to this. I want to see this scaled so that anybody can get one of these pretty much any time, and there's no reason why they can't. So this is an ultrasound performed by a dental hygienist, short axis view. There's some plaque. This is actually barely heterogeneous, relatively homogeneous plaque in their carotid bulb. And what's new. So this was the view that that's where we would stop up until about 6 months ago. But then Vasal Labs has come along. They have been studying this technology for quite some time. And now it used to, I mean, so if we saw a patient with this finding, we would then schedule them for a standard CIMT study. 1 day a month at my office. It would cost is around $400. Insurance does cover a portion, if not all of it, in some cases, but not all. It's a bottleneck, and people can't always make it. And it's important to have that measurement, so that quantitative measure of the intima media thickness, because that's what we follow to demonstrate to individuals that they're improving. So, for instance, it's not just enough to measure the CIMT. You want to make it better. And so this is an example, less than 2 years, a reduction in the intima media thickness percentile ranking from the 95th down to the 53rd, and the arterial age equivalent from 85 to 63, by addressing as many of these individual root causes as possible. And so we need to measure this from time to time to see if our treatment is working. Well, how do you do that? So up until recently, you had to have a sonographer with a $50,000 ultrasound machine and a 1 day a week, and send it off and be interpreted. And previously, the results took about 10 days for the results to come back. So now I can do this ultrasound, and I have 2 dental practices now that are doing this additional view, measuring the intima media thickness, sending the images via the Butterfly cloud interface, which is then uploaded by DICOM to Vasal Labs, and they get a report that looks like this in about less than 2 days. So and then the patients can see the location of their plaque, and this isn't an active, but when the report comes on a PDF, they can click here, they can actually see the images and be shown that. So then we offer, my part of the deal in this interaction is that for patients who have a test done in the dental office, we don't really expect the dentist to be able to explain this any more than you would expect me to explain how a root canal works, or what is done, or how to do an implant. So we offer patients with their report a discovery call, a 15 to 30-minute video report call to discuss their findings, and how, as a medical provider, I can then collaborate with their dentist in reversing this problem that is a ticking time bomb. So from the very first time that Tom and I apparently attended the same first preceptorship, but we never actually met at that time until later, it was all about the oral systemic connection, the dental medical collaboration, but it was always these bottlenecks of cost of equipment, of learning a task, and just then communicating with one another. But one of the key elements was, I just want to show this example today. So this is that gentleman that I was mentioning earlier, the healthcare worker in the San Francisco area. So he works as a nurse in an ICU, and I talked to him I think it was about 2 weeks ago, and he was very proactive. He had heard about the BaleDoneen method. He found me in that way. He wanted to have the workup done. I said, well, it'd be great if we could get a CIMT done on you. Well, I checked again. No provider would CIMT within 3 hours. And I said, well, I'll tell you what. Do you know anybody who has one of these point of care ultrasounds working in the ICU? Because that's been the focus of Butterfly, has been inpatient ICU and emergency medicine docs. He said, well, I might. And so, well, what I'm showing you here is not a Butterfly ultrasound. These are still captures from a video so he found a standard ultrasound machine. I don't know how he got the sonographer to show him how to use it, but apparently must have a good friend, and did this ultrasound on himself, the very first study he'd ever done on himself. And so these images, I hope I can get this to work. This might not. Well, I thought so. Well, the point is that he was able to show me a very nice image of his intimate media thickness. There are short axis views that show fairly barely heterogeneous plaque, and I guess I can't get that particular image up easily. I'll work on it maybe during the Q&A. But the key thing is that he was able to, with one try, get us this image. My point is the learning curve for this is not a 2-day seminar or 2-day, travel to a location, spend thousands of dollars. And we're not trying to replace or replicate the work of a certified sonographer. We're trying to do this well enough to show the information, to get the patients to motivated to act and to follow through and to be followed so that we have a measure that's good enough. And so that is really the key element to this message tonight. And just to show that turnabout is fair play, if I can get a dentist to do an ultrasound as part of their examination, because I do salivary diagnostics in my office as a medical doctor. Patients ask me all the time, well, what do we do with the results? Send you to your dentist. If they shrug their shoulders, don't know what to do with it, we'll find you a dentist for a second opinion that does know how to deal with these issues. And so I think in the interest of time, I'll stop there, but just hopefully have made the point that it is possible with the proper support for this ultrasound imaging, this very attention-grabbing imaging, to motivate patients in the dental practice. And I think this is maybe it sound over the top, but I think this is really the genesis of an alternative, a meaningful alternative to the standard healthcare system that has become too reactionary, too bureaucratic, too top down, and just too unresponsive to what patients truly need. I'll stop at that. And Tom, you want to lead the question Q&A? You're muted.
There we go. Thank you, Craig. So let's talk a little bit, because the other thing that you and I have kicked around a lot. I see somebody on the call, Dr. Randy Bunton, who I met this summer, and in the world of salivary diagnostics, he's doing something pretty amazing, in that he screens all of his patients. And the minute I met him, I was just so envious, and I was just thinking about you have a dentist in Arizona. I can't think of his name off the hand, that has begun doing this in this initial phase at no charge. And what he's trying to do is to kind of become familiar with it, have the hygienist be comfortable with what this workflow looks like. So I haven't been able to accomplish that yet. I'm envious that somebody kind of jumped the gun on me because I was on this years ago, but I just haven't been able to, for a variety of reasons. So talk to me about that, because it sounded like it was, as it was presented to patients, they were very receptive to it, right? So they're here to get their teeth cleaned, and they said, would you be interested in doing this, 5 minutes, and we're going to do a screening. Talk to us about that, because once again, that's the integration. So what did that look like?
Well, what I'm doing right now is actually that's the protocol on one side, and you do that twice, and then you put the patient's information into the interface and send it. So it literally takes about 5 minutes. I have my plea has been to not overthink this.
Right.
We don't only screen high-risk women for breast cancer or cervical cancer or high-risk men for prostate cancer. We screen all of them. And we find that many people who are at high risk do not have cancer, and many people who are at low risk end up having cancer. And the same thing is true with arterial disease, especially when our risk profile is somewhat incomplete. So the critical thing is, my plea is scan as many people as possible. So that means low cost of entry. and I won't go into all the details because I know we are kind of running up against time, but there's a sort of scan now, pay later option. So to scan everybody, the images are there. They can pay for a report if they want it. The cost for the report is $99. So I find that anything under 3 digits, you have much better chance of them saying yes. You add that extra dollar, make it $100, and suddenly it becomes a big deal. And the same thing with salivary diagnostics, and it generally works.
Yeah.
And then each practice is different. So we try to stay agnostic about some practices want to do it as a loss leader. And I think they'll find out that they will have more patients engaging with salivary diagnostics, with airway assessment, with cone beam CTs. Those are all mean better care and better revenue. And I'm a firm believer that, it's moral to make more revenue by doing better care. For what it's worth, we're finding is that typical practice would charge probably about $50 to $100 for this scanning. So think of in terms of 5 minutes of effort by the dentist, or in most cases by the hygienist, or an assistant, or anybody else it's not a medical skill that we're looking at. It's really a hand-eye coordination and an imaging skill. So it's more like an X-ray tech than somebody who really knows what to do about this problem. So there's I think we've overcome a lot of the issues that come down to standard of care. This is so far above the standard of care. How can you be accused of missing something?
Right.
Scope of practice, the interpretation is not done by the dentist, nor is the treatment. It's just a technical component. And so I think there are for anybody who's interested in the least, what I would recommend is I can put a link into the a chat to our discovery call link, and I'd be happy to chat with them one-on-one about that.
And I think the other thing that you haven't explained in its totality is the platforms that you've built to make this happen, right? So it's not like I take an image, what do I do with it? You have gone to great lengths not only to build that platform, but when I became a patient of yours kind of during COVID, because you were the first person to really, really execute a good virtual program where you can be my physician. You're in Illinois. And when you go into your Cure, was it the Cure platform or whatever it's called?
Yeah. So you're referring, and I'm going to share my screen just real briefly again, if you don't mind. So what you're referring to is curecoach.app. And so this is it's a data gathering, messaging, and collaboration platform. So patients who are on this. So for instance, today I had an onboarding discovery call with a patient. I had her register on this, and I had her make a connection request to me and to her dentist, who happened to be Dr. Krisman in Arizona. So now we both have access to her record on this platform, where we store common documents, so we can upload any PDF report. It's not interoperable. That's kind of a pipe dream, given the vast variety of interfaces with EMRs and EDRs and all these kinds of things. It's like just kind of a wallet where patients can put reports in. We can actually see them. But I think pertinent to this, Butterfly already has the platform. They have so when you scan, you log in under your username, and you scan it to one of these archives that's assigned to you, and then I can see the images immediately, or anybody who has access to the platform, which is all HIPAA compliant and integrated. And several other kind of neat features. One is, if I want to send the images to the patient, I can copy the link and paste it into a email or a text and send it to them, or anybody who wants to see them. Those images are de-identified. We can create a report using templates. It's all, for lack of a better word, pretty darn slick. So it's taking all the real barriers to this kind of healthcare have been cost and logistics. And I think, the cost is very reasonable, and the logistics allow this to scale. And then finally, one of the things with what makes my practice a bit different is I've been focused on reducing the footprint and the cost and the complexity of this down to the elegant solution that is affordable by as many people as possible, including satisfactory reimbursement from a decent mix of insurance companies. So I bill my services to health insurers, and although I wish they paid me more, they pay, if I get a decent mix, I get paid enough because my overhead is so low. Imagine if my only overhead was my laptop computer and I could do all this by telemedicine, which I do probably about 40% of my work now by telemedicine, because that it just works.
And I think, and you and I have talked about this, one of the reasons why the BaleDoneen method, even though it's been around 10 or 15 years, has not had the penetration that it should have is because from its inception, it was a concierge model, right? So there's a couple of guys that do the concierge model here. And you're the first person that's really tried to make this accessible. And I really respect that for a lot of reasons. Okay. So my personal private practice years ago was fee for service, but the practice right now, the young doctors that I'm working with are concerned about accessibility. Can we give a high level of care? So we participate, and it's not easy to do that, but I respect their mission. Okay. I really have a lot of respect for that. The accessibility, can we bring a super high level of care to patients that want it, right? And so that was one of the areas of differentiation of you personally than anyone else. So if we can scale what you're doing and what I'm doing and really reach more people, I think it's a noble cause. And I thank you for it's difficult, but I appreciate you for doing that.
Well, thank you. I appreciate the kind words.
Sue, jump in.
Yeah, I'm just going to jump in before we run out of time. I've absolutely been fascinated with listening this today, and I know that I jumped onto this bandwagon only 4 years ago, 37 years into my dental hygiene career, and what a noble thing to do. I wish that I was the dental hygienist that was able to work this way. The problem I face, and I've actually taken all of Tom's work and brought it to the Southern Hemisphere, literally, and the work of many, many other people. So I'm riding on the shoulders of all of you to share this with the world, and I'm making it my mission to do so. But in here is the question that I get faced quite often with when I end up at a practice: isn't this out of our scope? And I know you've touched on this a few times through today's talk, but people are petrified of litigation by stepping into areas that are out of their scope. I go back to that slide. If you're doing no harm, then why not? And I used to take blood pressure of our patients, and right. So can I get you to step in and answer that? I think you know where I'm headed with the question.
Well, I think, I get this actually a lot less than I thought. I did a presentation for the American Dental Association about 4 months ago, and I was expecting this to be the topic of the first question out of the box. Didn't even come up. Now, maybe they just said it wasn't a serious, concern anyways. It was nowhere, so why even debate it? But I alluded to it. You brought up the perfect example. You don't treat hypertension, do you, in your practice? Yet you take blood pressure readings. With that is a slight expansion of the dental scope, but you're a healthcare provider who is alerting other healthcare providers who have the expertise to deal with that to this finding. And my recommendation is it's very easy. It should be relatively easy. I'm here, like, for instance, the dental x-rays. We don't expect the dental x-ray technician to read the films. They take them. They perform the imaging. This is the analogy. Yet the images are sent elsewhere for interpretation, and here's where you go for an explanation of the interpretation and its implications. That's the medical side. So that's where Pure Coach, my company, which I hope to scale in terms of services, and it's kind of a chicken and egg thing. Do I have 1,000 providers ready to scale this? No. But if I had 10,000 patients sitting in a hopper waiting, I could find the providers, who would be anxious to treat those patients. And by the way, for the cash-based practice or concierge practice, God bless you. I'm all for it. In my location, it just wasn't a going concern. It wasn't a possibility. but who benefits from excessively high overhead? Nobody that I know of. So anything you can do to raise, attract more patients. If if your margin is 3 or 4 times the margin that I'm making, God bless you. No problem. Use the same tools. Why buy a $50,000 machine if for your purposes a device that costs less than 20 under this reduced price, actually I think it's around as little as $2,500. And why something on a cart that you have to wheel around when you can carry this around in your pocket. So but going back to the scope, I think yes, it's a concern, but ultimately standard of care, I kind of touched on it briefly. What is the standard of care in the dental practice for cardiovascular disease? Nothing, no look, right? So anything that you do to raise awareness of it, I would argue in court, and I don't think there's a plaintiff's attorney who will attack this. I mean, it'll be very easy to defend. What is the standard of care? To do nothing. What did you do, doctor? Well, I looked. I did something. I tried. I referred the patient. If anything, anybody takes on the liability, it's the interpreter. And I think really, we are very, very careful. If we see the slightest thing, we offer at least a discovery call. Because often then we'll find out other things in that conversation. Oh, I had a coronary calcium score and it was 300. What did they decide to do about it? Oh, they said, wait till it's 600, then we'll do something about it. Nonsense. Early intervention. That's all it's all about. So I hope I addressed that. Yeah. Thank you.
I think you have. And Dr. Bax, if I was to buy, my question was going to be how much is the butterfly, because and you've just answered it. It's $3,000 or $2,500 at the moment. But if I had this in one of my Larkin protocol practices where we're already testing the microbiome in our patients and we added it as an adjunctive thing, could we refer them to you in the US? Yes, we can.
That's
or interpretation.
I think it's unclear. During COVID, so many of the rules about interstate, practice and medical licensure were relaxed. Nobody's really paying attention to it. Ideally, what we would want to do, if possible, is find a medical partner licensed in the same jurisdiction who we could train to take that on with the coaching. So, I don't know if there are any lawyers on the call or how much trouble I might get in, but informal advice and discussing concepts, I'd be happy to. But I think in terms of hosting the imaging and setting that all up, there's no real barrier technically to sharing these images and learning from it. And to be perfectly frank, the rules are set up basically to stifle innovation and patients and things that patients need. And so a certain willingness to try to push the boundaries of the rules, I think is I'm not going to apologize for that if somebody criticizes me for it, to be honest with you.
Look, I think if I'm diagnosed with cancer and I had to go to Switzerland to find a doctor to cure me, as a patient, I have a choice of where I want to go. So if I'm sitting in a doctor's or a dentist's chair and I've been told that the screening has showed something abnormal, I guess I'm allowed to go where I want. So it's my choice. Tom, did you want to add to that? Sorry.
Yeah.
The problem is define what it means to go. If you travel from Australia to Springfield, Illinois, and come see me, there's no problem. The question is, have you come to me enough, and where will the lawsuit be adjudicated in the event? So that those are all legal issues that I'm not qualified to really comment on. I know that it's there. It's something of concern. We need to solve it. But in the meantime, let's not let the lawyers and the bureaucrats stop us from trying to innovate good patient care.
So I have a question so that I understand this correctly, Craig. So what's a little bit unclear to me is, as your demand increases, are you going to address the bandwidth issues with more providers yourself personally? Or did you say that ideally what you would like to do would be like to partner for me to find a healthcare provider in my town and you would partner with them? Is that the preferred?
Yes. I mean, okay. Ultimately personally, I think that there's post-COVID in the current environment, there is a pool of disenfranchised healthcare providers, and this doesn't need to be medical doctors and DOs in many states. Now, nurse practitioners practice independently, and to be honest with you, I think they may be a better fit for this coaching role to learn our protocols. I see Barb McClatchy is on the call on the meeting. I'd love to get the BaleDoneen graduates, to take a look at this and see it as an opportunity. But I think I love what Brad and Amy have done in terms of education and showing us the possibility of cardiovascular disease, metabolic disease being reversible, even to the point of considering it cured and a money back guarantee and all these things. What I would like to see is for us to come together and bring a more scalable solution, one that's more, it has to be digital, it has to be, deliverable across distances, it has to be convenient, it has to be lower cost. The Tony Robbins approach, well, that's wonderful for somebody that can write a check for $25,000 to attend one of his programs and seminars. But if our real goal is saving lives by and large, that's not the answer. It might be the first adopter, but it's so globally overwhelming for the average person. I'm just trying to get them to eat less sugar in most cases, let alone take, aging management, hormones and the like. So I think the provider pool is out there, but they're struggling to find the market for their skills that will pay them what they're told they have to charge, which I believe that I would make the case that we don't have to charge that much, but we do need to have a much more lean model. I practice with an office manager who's quite frankly not busy at all. Most of our appointment, so much of my stuff is digital. I can work for several days without any support because of the way I do things. And I know it may be hard to believe, but when you bring your overhead down that low, then you don't necessarily have to, demand the fees that some are demanding.
Yeah. Okay. No, that helps me understand that a lot better. I didn't know that. Okay. So questions, Sue, get us some questions.
Yeah, perhaps just unmute myself. Perhaps if anyone in the gallery has any questions, I know we have a butterfly representative on the call today too, Pam. I think I've seen Pam Kelly's there. I'm not sure if she wants to come on and add anything at all. Pam?
Hi, I'm here. Thanks for having me, and I'm happy to answer any questions specifically about the product itself. So available to.
We can't get a visual of you, can we? At all?
I'm so sorry. My camera is not. I cannot get it to work this evening. My apologies.
Okay. Does anyone in the chat room today have a question? You can just throw it up there. If you're too shy to show your gorgeous face, I'll ask for you. Gentlemen, I've actually found that extremely fascinating, as I always do. I really look forward to a world in dentistry where we start to overlap and stop working in silos as we have been. And I know that when I was 23, I had a periodontal patient who was only 36 years of age, treated him for periodontal disease, over 4 appointments, and he did not return for his 3-month follow-up because he had died of a massive heart attack. And in fact, that was the seed that was planted for me since the age of 23 to chase this down. So it really pleases me to be rounding off my career back on this conversation. So thank you. Alice Hale has a question. How is the training done? Alice, I believe, is in the US as part of Tom's class or another online digital format. Thank you, Tom.
That's for Craig. How is
actually I've trained most of the people that I've brought on online. And actually Butterfly has a very interesting technology called teleguidance that allows me to sit at my computer and see what the student is doing both with pro placement, images they're acquiring from anywhere to anywhere. But I've also done it with Zoom. And obviously, face-to-face, hands-on. I mean, I can see a variety of models, training sections at national meetings. But really, ultimately, to be honest with you, Butterfly has such a, I hate to sound like a commercial, but they have such an extensive library of video tutorials that are accessible from the platform. So if you want to look at a tutorial while you're getting ready for an examination, you click on the education button, you click on the category, you click on the specific tutorial. There is one in there that specifically addresses this protocol, and so it's and I look forward to the day when we're partnering with Butterfly to bring this into this specific scope. But the answer is it can be done online, believe it or not.
Wow, that's awesome. Randy, I want to talk to Randy. Randy Button. Can you unmute Randy?
Randy, let me just find Randy, make sure he's unmuted. And Randy, do we have your picture as well?
I'm looking at him.
Oh, good. Asking.
So let me tell you a little bit about Randy. So I had a roundtable discussion, about I don't know, it was midsummer. It was about the failing dental implants, and I got the small group together, and Randy was in that group, and I was just so blown away by him. As first off, he's a really cool guy, but just such an accomplished clinician. And he was talking about doing salivary diagnostics on all new patients. It's a part of his protocol. And, and once again, I'm just sitting here in envy saying he has so much data at hand, having that biofilm DNA profile on every patient, I mean, that's just like a dream scenario. So if there's anyone that I know that can do something with this, Randy, tell me what you think of this.
Yeah. So, hey, everybody. Hope you're doing well. I know everybody's had a long day. So that's true for 5 years now. I've been doing testing. And when I came to Kentucky, I had, I think, with me 111 tests and retests for taking folks through periotherapy or gingivitis therapy and all different types. So one of the situations when I landed in Kentucky was one of my patients that I had just started on antibiotics so that we could do her scale and root plane and periotherapy. She called me and said, I can't take these antibiotics. And I said, well, stop taking them. We'll figure this stuff out. So that sent me on this entire other pathway with ozone, and it's still blowing my mind. But, as far as the Butterfly, I think adding that would be perfect. And it's not expensive to get into, but it's also going to piggyback on top of, in about 2 weeks, I'll be doing A1Cs on everybody. Wow. A1Cs in my practice, they're super important because they dovetail. I do so much surgery with implant surgeries and perio surgeries and therapies, full mouth rehabs, whatever, that all of this plays in. Like, I don't see how it is not supposed to be part of it. Well, since I've been doing all this, now I have more physicians in my practice. I have cardiologists. I have, I'm getting referrals in from ENT from doing things. And that's because I've set up a very specific communication pathway to these physicians. So every single new patient that comes in, and I can't handle more than probably 6 or 8 new patients a month, where, a lot of dental practices want 30 or 50 or whatever they can get. Right. I can't do more than 6 or 8. And by the time we take them through the new patient exam and we gather all this information, we have the consultation with them. We have open lines of communication with their physicians where we send information to their physicians and we ask for the physicians to send us a response back. So we send, a piece of paper that we have everything filled out, and we leave them a space for them to write something out and send it back to us. And now we're getting a lot more of those. So, I know we're in South Mississippi, probably the last state in the nation to do anything progressive, but we're doing it. we're flat doing it. So
Wow.
I'm looking forward to. In fact, I've been I got the email a couple of days ago about the butterfly. I had spoken with them maybe 6 months ago, so now it's time to probably pull the trigger on that and
Wow.
stack that on top of my A1C and all of my
Yes.
salivary testing. I'll tell you also, just this week we had a physician, a medical oncologist, a new patient to the practice, and she was a microbiology major in college before she went to medical school. And by the time she got to the microscope, with the phase contrast microscopy, her mind was blown, and like she was playing with it and she couldn't wait to see things, and she was pointing stuff out, but she was asking why we didn't have to gram stain things. And so, my hygienist, I have 4 hygienists, and they all can be chairside with me, so they don't do hygiene all the time. They're chairside with me doing surgery. It's interesting. So anyway, that's my practice, and this will fit perfectly into that.
So here's what you need to know.
If I
Go ahead.
may I comment?
Yeah.
I think what you're describing is extremely high level of patient and
Yeah,
staff engagement.
Yep.
And that's what it really boils down to. And it's in the comparison to the hemoglobin A1C, I think, that's a very important test in terms of risk of patients getting infections, from surgery of any kind. But you'll find far more sick people who need to take action from doing the ultrasound, because the A1C is the last thing to change in that progression through insulin resistance to pre-diabetes to type 2 diabetes. And so many people with that pre-diabetic insulin resistance stage already have arterial disease. And so it's just like you show them, it's like a little tumor in their, in their artery. And I think those are the analogies to use. So I hope you do pull the trigger. I think you'll enjoy it. And I think it does fit very well.
Yeah, I think that the A1C for us, it's a normal part of communication for the physicians, and the patients already know the term. And so if they know the term, then it becomes easier for communication, which greases the skids for all this other crazy stuff that we do, which isn't actually crazy.
Yeah. So Sue, to get back to your question about scope of practice, okay, here's A1C, right? And I can remember, I think it was 2 or 3 years ago, Delta Dental did a pilot program in New Jersey where they were paying for A1Cs and, kind of, I don't know why they were doing it, but dipping their toe into it. So I think getting back to Craig's point is, we can safely do more for our patients than we think. We shouldn't be always, thinking of the worst legal consequence of this. And the A1C is a perfect example. So what I was going to say is, in my advanced age, I have found, envy is a horrible emotion. I envy Randy. He's one of the few people I've ever knew that I'm like, holy smokes. He brings up that negative, like, boy, I envy him. He's a mover and a shaker. And once again, he's in South Mississippi. My private practice was in Arkansas. So when you're doing things like what he's doing and what I did in places like that, that's noteworthy. Okay. So when people have all these psychological barriers, well, I can't do this here. I live in Kentucky, he is setting an amazing standard, and I was so happy to get to meet him this summer. Thank you, Randy.
Honestly,
A lot of fun.
I think those smaller communities are the source of innovation in healthcare. The closer you get to a major metropolitan area, especially if there's a university medical center associated with it, you get groupthink, you get the opposite of innovation. The last 3 years have taught us so many things about what we thought about people we should have trusted.
I think so. Randy, we haven't met. So I tell you what, if Tom's got envy, I've got hygiene and employment envy, because hell, I would love to have worked for someone like you. And hey, I might come out of the cobwebs and come and do it. I just wanted to round off before everyone drops off and has to race off back to their work. Dr. Larkin, I am coming to America on between March 2021, 22, 23. I would not miss it for the world. I wanted to just get some hints and tips. I know we're always seem to be preaching to the converted, but please bring your friends. Please come along, have a look at all the toys. Everyone here, you've got to know how simple this is. This is so simple. None of it is hard. And the missing piece is actually people don't realize how much money there is to be made by what I call the rent roll in your dental hygiene department. So by getting people back regularly and having them so stuck to your practice that they'd go nowhere else, you will attract hygienists, and then a second, and then a third. And one of the reasons I've got 7-figure hygiene written there is because my goal to dentists is go and find those entrepreneurial dental hygienists who will create the business within your business, and your patients will become so engaged and healthy, your clinicians become so inspired, and you just skyrocket profit and success. So Tom, please give a plug to your course, and I will see all of you there. Tell all of your friends. And thank you, Dr. Bax, and thanks, Randy.
So I've kind of renamed my annual event and the Innovators Conference, because what's happened is from its inception 4 years ago is that for whatever reason, I've just attracted these innovative individuals, the ozone water, the airflow, Craig, whatever. And the concept resonated with people because everyone's interested, but they just don't know what to do. But one of the things that you just pointed out that's happened is that as we've progressed from year to year, everything has gotten more simple. Craig's deal is going to be immensely more simple than it was 2 years ago. My presentation is about simplicity. When I get into like air polishing, and I talked to you offline today about air polishing, simplicity. It's way too complex. And the more that we can do this collectively, it's unbelievable the synergy between all of the presenters and how each conference evolves. And that's what really kind of keeps me excited. So March 22nd, Lexington, Kentucky, horse capital of the world.
We are in Australia. It's nearly Christmas. We usually wear we call them togs and bikinis with our Santa hats on. It's very hot here, but today there is a thunderstorm, and I'm likely to go down at any minute. So I'm just warning you all in advance.
Okay. Any more questions? Any questions in the chat at all that we need to get real quick, or take a couple more questions? No. Very good.
Randy and Dr. Bax, will we see you in Kentucky? And will you be on the bourbon bus or the horse bus?
But I did the horse.
To be there, we'll still see.
Yeah.
What's that, Dr. Randy?
Said I'm hoping to be there. We will see. I know that we have something scheduled that's been scheduled for the last year, right there in that time, but we'll see. I'm still working on that.
All right. Very
The
good.
Dr. Bax will be there, and you'll be on the horse bus.
Yes.